Today I just wanted to kind of demonstrate how adolescents can migrate to the adult healthcare model with the least amount of interruption in their care, and one that's developmentally appropriate. I hope that you'll understand what the need is to transition to an adult model of care. As we get older, we start, accumulating all these adult problems that need adult doctors to take care of you. And even though we love our pediatric doctors, at some point we need to move on, and that's a hard time for most of us. And also how you adults out there that have HH have already transitioned to adulthood, how you can kind of start to take control of your care at this point. So broadly stated, the goal of transition is to maximize your lifelong functioning and potential through receiving really good, developmentally appropriate care with the least amount of interruption in that care. So as we know, adolescence is a time of change. There are physical growth and changes from puberty. There's the development of personal identity, autonomy, and independence. The relationships that the adolescents have changed, whether it's with their siblings, their parents, peers, friends, school teachers, and sometimes employers. They get a little bit more difficult. They're engaged in social activities they weren't previously engaged in, so there's a lot of new things going on. And obviously there's changes in school and sometimes employment as well. And if you compound this time of drama and angst with someone with a chronic condition, it can be really overwhelming, because patients with HH, they don't have a free pass through adolescence. They have to go through this with their chronic condition. And so what's the difference between transition and transfer of care? Well, we all have transferred our care as adults from doctor to doctor. It's really meaning you're just changing doctors. We do it for a variety of reasons. We change insurance companies, we move away, we want maybe a fresh pair of eyes or a different perspective on what's going on, but we do it for a variety of reasons. There's really no structure involved beyond faxing medical records from one office to the next. But transition is a more process-focused approach. It's purposeful and deliberate action, and it involves the healthcare team, the individual themselves, and the family. So why is transition so much more effective than transfer? Well, as care delivery changes, or the care that you receive, it can cause a lot of anxiety and disrupts care. Pediatric and adult approaches to care differ significantly. With the pediatric model, it's really family-centered and it's very developmentally appropriate, whereas the adult model of care, it's very individualized and patient-focused. And it is expected that the individual assumes responsibility for themselves and takes ownership of their care. So we've all looked like this before from time to time. So what the benefits of a smooth transition could be, our parents' anxieties can be lessened for one. Youth autonomy can be increased depending on the cognitive and development abilities of that person. The pediatric clinician can be much more comfortable handling over care to the adult doctor, and the adult clinician can better meet the needs of that individual. So where do we start? This is a great question. First of all, I'd want all of you to identify what the goal of transition would be for your family. Not all individuals with HH are ever going to be completely independent. That's something you need to work through with your family and kind of come to grips with, is this someone that's going to be independent, or is my child always going to need some level of support, whether it's from the family, the parent, or some form of guardian? And then recognize what the barriers are to transition. There's a lot of bumps in the road and hiccups as we go. And if you understand and are aware of the barriers, you could probably help yourself navigate a lot more smoothly through that transition. And then start the conversation. As a mother of a 23-year-old daughter that's about to get married, I can tell you we had little conversation about health care. I explained what co-pays were and some of the differences between insurance companies, but that was it. She doesn't have a chronic condition, so we really never had this conversation. And a lot of families, I don't think about this conversation till the child's 18, and now they're left with nowhere to go in a process-focused approach. They just have to change doctors, and it creates a lot of anxiety, and it's always disruptive of care. So what are some of the barriers to transition? There's a lot of family concerns about the differences in the adult healthcare model. There's many differences in them. And there's also that feeling of loss of control. Every state is different in how much they let parents come in to the exam room when they're dealing with an adult patient. And the loss of control of that is very worrisome, especially if the individual has some kind of cognitive problems, even if it's minor. Now, although a lot of adolescents are fighting for their independence and autonomy, some of them are quite comfortable letting their parents continue to take control. So you often need to get some of their buy-in. And then there's the pediatric clinicians that have a hesitancy to let the kid go to an adult model of care. A lot of times they've established care with this child and kind of grew up with them, and they know they're the best suited to take care of this patient, but they're not going to be ongoing as the patient get older. But they have that hesitancy, and a lot of them keep them around long after they should be there. Well, the adult clinician, a lot of them are very unfamiliar and uncomfortable taking care of adults or young adults with childhood chronic conditions. They're unfamiliar, especially with HH. That's a rare disease compounded with a chronic condition. You know, it causes anxiety on the part of the adult clinician. And that goes whether it's a primary care doctor or any kind of specialist. So a few years ago, the American Academy of Pediatrics and the American Academy of Family Practitioners independently recognized this need of adolescents, especially the ones that require a variety of specialists to manage their care. And they recognized that there was a gap in these services nationwide, probably around the world. So they actually established guidelines for hospitals and medical practices to use to set up a transition policy. There are a few nationwide. None of them are extremely successful in managing all of their patients. They're all done much differently, a lot of them supported by foundations that eventually run out of money. So really the ownership is going to have to be on the patient and the family for most of this. And the takeaways of the core elements of their guidelines really include for the family preparation and planning, and this is key. This is not a one-time event, it's a process. So things you have to ask yourself: is your young adult or child ready for this transition? Are you ready for this transition? You need to assess what your own perception of transition is. Are you looking at it as something that you are forced to do, or are you looking at it as an opportunity to get better care for your child, or more age appropriate, I should say? And then recognize that this change is really emotional for everyone. And then when, as far as planning goes, when and where do you start and who can help you? The first thing to do is to observe and track readiness, and you start this with a young adult. You need to pay attention to what they know, what their knowledge level is about their medical condition, and their ability to understand their treatment plan. What is their ability to provide self-care? What is their emotional readiness to change doctors? And are you able to relinquish some of this control? Then once you move on, you start providing the education about the health condition, about the treatment, about life changes and how life changes can affect the condition and vice versa. And when I say life changes, just anything that happens as you get older, starting new employments, doing schoolwork, and just meeting new friends. And then, of course, management of the risks. Do they really know how to manage their own risks? And then involve the youth in the decision-making and taking responsibility. It's not hard to even have a young teenager call in a prescription refill with you sitting next to them, or have them make their own appointments with you sitting next to them in the beginning. Have them track their medications and hold them accountable for missing the medications. And then start with maintaining a medical record and an emergency health plan, and I'll show you that in a minute. Ask the pediatric doctors to direct the conversations to the young adult. You know, remember that pediatric doctors usually establish the relationship with your family when the kids are very young, and they have a tendency to talk to the parents, and that sometimes, you know, continues as the patient gets older. But if the individual, the young adult, feels like he's the center of attention, sometimes that helps them take ownership in the whole appointment. And of course, to the best of your ability and theirs, empower the young adult to take charge. So understand that transition planning is a process. The the healthcare guidelines that were established in 2011 suggested the process start at age 12. And again, depending on the cognitive and developmental abilities of that person. But take baby steps, address the healthcare needs now that your child has, and the gaps in that. What are you not getting? And seek out those services just to help the smooth the transition. Research the potential adult providers and the pending transfer date years in advance, so there's no surprises. And seek out get acquainted material. Sometimes the adult offices do provide sometimes open houses, or else you can just go online and show the adolescent just even a picture and a bio of a doctor, so he doesn't feel like that person's a stranger when they have their first appointment. And sometimes, there's very few and far between, but there are some organizations, or I should say hospital care systems, that have joint visits with the adult and the pediatric doctor. They are few and far between, but you might encounter some of those. And then, of course, one of the most important things, in my opinion, is creating and maintaining a health history. And I'll show you these forms tomorrow in the workshop. But the most important ones are the medical summary and emergency care plan. And I hope you can see this fairly well. But this is basically something that can be updated online, printed out as necessary, and given to schools, employers, any kind of social community leaders, anyone that might have responsibility for your child at any given time. And you can update and just print out, as I mentioned, as necessary. And it just contains all the pertinent information in case there's a problem and someone needs to care for that person. So, you know, allergies, medications, emergency contacts, what doctors, hospitals, and pharmacies are you already established with, a list of the problems and potential recommended actions, any prior surgeries that would be pertinent for any EMS to know, and any lab work or any CAT scans or anything like that that's significant. You certainly don't want to write down every one you get. And then any kind of equipment or assisted devices that normally would need to go with that youth, that sort of thing. And equally as important is the family health history form. I know I was never given this. Anytime I go to the doctor, I kind of have to think back to what illnesses my parents and family members had. But this is a great way to help your youth manage his records. And so use the pediatric team as a resource. They usually know who is experienced in the specific condition that they're working with you now. And even if you can't find someone with HH experience, he can find, or he or she, the pediatric doctor, can refer you to someone that they can trust and they know is open-minded and maybe driven to learn about it. Ask them to send an introductory letter on your behalf to that adult doctor before the first visit. That can be a paragraph or two of just the most important information about treatments and what works and what doesn't work. It really helps bridge that gap. And always make the appointment with the adult provider prior to the last appointment with the pediatric doctor. It's a lot easier to meet someone new before that final chapter is closed with the pediatrician. And ask the pediatric team to serve as a resource for the adult doctors for about up to a year after the transition is complete. It makes everyone feel more comfortable. And also, some hospitals or medical offices might already have a transition policy. Ask them about that well in advance. So the transition's complete. Now, how can you help the next people going through the same thing? And the most important thing to do is give feedback, not just to the pediatrician, but also to the adult office. Make sure that they know what struggles you encounter in going to their office. So now I'm just going to touch a little bit about those that have a little bit more intellectual challenges than others. First of all, once you realize possibly that your child will never be completely independent, understand that there are going to be feelings of grief. You have to wrap your mind around that, really, in order to move on. And recognize that parental involvement will continue, or some form of guardianship, throughout that person's life. And then get started just educating yourself and your youth to the best of their understanding on legal issues like guardianships, trusts, wills, who's going to care for them after we all pass. Those kind of things need to be addressed. Long-term care planning and community resources are out there. If you ever meet a social worker, make that person your best friend. They know what all the resources are in the community, whether they're inpatient or outpatient. State-appointed agencies have a lot of resources that most people aren't aware, especially just for respite, so you can have 2 hours to yourself on any given day. Churches, schools, some hospital programs, these are all resources for you. And support groups such as Hope for HH. It's a huge organization. That's what brought you here today. The Epilepsy Foundation. You could probably even find more. And especially with the intellectually challenged patient, acknowledge what challenges there are in the adult office, because there'll probably be several. And once you understand this, it's easier to prevent some of the problems and navigate through them. So usually in adult care settings, the offices are devoid of anything appropriate to the developmental age of someone with an intellectual challenge. Yeah, I mean, if you think about it, they have TVs with an adult show on, they have Time magazines or USA Today. There's really nothing to grab the attention of the intellectually challenged adults. So facilities are usually not adequate for any kind of personal care, whether it's diaper changes or anything. The skills of the staff, the front office or the back office, they're not really strong in dealing with people with behavior problems. Their first mode of action usually is contacting security. So, I mean, there's a lot of different things you have to navigate through. Behaviors can be intimidating to other patients in the waiting room. So sometimes you can kind of find tactics to keep, you know, your child, what's the word, managed. And then one of the most things that, well, actually, Lisa and I had talked about it, is frustration in not being allowed to go into the exam room when your child is an adult. Because patient privacy laws, you know, limit what they're allowed to do. So talking to a practice manager in advance, finding out what the policy is of that office is really crucial. So you're already an adult, and now you're just trying to manage it. What now? Well, first of all, you don't need to go to an HH expert for all of your problems. As you learned today, as far as endocrine management goes, whether you have HH or not, precocious puberty is really managed the same way. Diabetes insipidus, understanding, you know, those causes can be managed by someone that isn't an HH expert. As far as cognition and behavior, a lot of patients report back to me that they have a lot of success dealing with therapists that have experience with traumatic brain injuries, and sometimes they can help with family therapy. And occupational therapists and psychologists have experience with memory problems, as we heard earlier. Neurologists, it's helpful if they have experience in HH, or at least an open mind and a drive to learn about it. More helpful before surgery because you might get diagnosed earlier. The neurosurgeon's probably the one that I would have to insist you go to an HH specialist for the reasons you heard all about today. And especially maintain a health record. That can really help somebody that, whether they have an intellectual challenge or not. So takeaways just from today is transition's a process. It's individualized. It promotes autonomy to the degree of the developmental and intellectual ability of the patient. And it results in care that's uninterrupted, coordinated, developmentally appropriate, which is key, psychosocially sound, and comprehensive. We will have the forms that I will have in the care notebook tomorrow. We'll have those forms online at Hope for HH and at the Barrow website in a few weeks. And that way you can kind of tailor them to whatever meets your needs a little bit better.